Um, Welcome. It's great to see everybody again. I'm Keith Coker. I'll be the host of the seminar today, as I have in the past. Welcome to everybody. As a reminder, I'm an emergency physician at the University of Michigan, and I am the medical director of a quality improvement network called MEDIC, the Michigan Emergency Department Improvement Collaborative. And we have partnered with the state of Michigan, MDHHS, on work to implement and support HIV screening in emergency departments around the state. And as part of that work, we have sponsored this seminar series, which we call a learning series. And this is the last one for 2025. And we have, as a topic today, decided to focus on HIV care and treatments, some of the clinical side of that, with the goal to really understand what care looks like in managing patients with HIV today. I think probably many of us still have this mental model of care that tracks back maybe a couple of decades and probably haven't really kept up to date with what care looks like today and some of the major advances and differences. Not really that ED care teams become expert in treating HIV, but I think more in the context of screening for HIV, knowing a bit more about what that handoff to care looks like, and being able to better help answer questions as they arise. So we have invited an infectious disease physician specialist from Henry Ford Health to join and provide us with a better understanding of all that. So I'm going to welcome Brianna Holman to the group. Brianna, I'm going to hand things off to you to get started. One other just housekeeping point as Brianna gets set up is we definitely welcome your questions and answers. So please use the chat function along the way. We'll be monitoring those things in the background and bringing up questions for Brianna, and then we'll definitely have time at the end to answer questions as well. All right, so Brianna, the floor is yours.
Okay. Can you guys hear me okay?
Yeah, you sound great.
All right. Okay. Like Keith said, I'm Brianna Homan. I'm an infectious diseases physician at Henry Ford. I'm also one of the HIV specific providers. I'm really happy to be here today, and I'm excited to kind of walk through what it looks like from the initial screening that you guys do in the ED for HIV, and kind of walk through that journey from that diagnosis to what it looks like nowadays living with HIV, especially in the HIV clinic itself. So today we're going to kind of walk through, like I said, just kind of give you some tidbits and tips and tricks about interpreting the screening tests, how to communicate those results, and then kind of that pathway from the ED with that initial, whether it's screening test positivity or confirmed diagnosis, to linking them with the HIV clinic. And then really want to focus on discussing the diagnosis with your patient. As Keith said, I think kind of getting us up to speed on what modern day care looks like, what living with HIV these days really does look like. I'll go over a lot of common questions that were asked by new patients, and then go over briefly the modern day treatment regimens and how that's changed from the early days of treatment. And then just a tiny bit on PrEP and post-exposure prophylaxis, just some updates. So why is this important? So I think everyone's aware that not everyone that has HIV knows their status. So the estimate currently is that about 13% of those living with HIV do not know their status. And one of the EHE goals is to increase the estimated percentage of people living with HIV to that know their diagnosis to at least 95% by now, which we're not there, and then remain there by 2030. So we've got some work to do. And then why is this important? There is a disproportionate amount of people that do not know that they are infected that are leading to new HIV infections. So this is data from 2016, and the percentage was a little bit higher of those that were unaware of their HIV infection, but it was 14.5%. But those were the source of 37.5% of new HIV infections. So it's very important that we do the good work that everyone's doing in the ED with screening and across the health system to identify these people so that the spread of new infections is decreased. So just kind of focusing on how do we screen, and this might be, there's likely information you already know, but I want to kind of go through all the nuances with the screening because it can be a bit tricky. So initially we do most initial screening tests are done with a fourth generation HIV immunoassay. So this is our antigen antibody test. It's the most common screening test that we use. So if that is positive, that reflexes to the antibody. It's called a differentiation assay. And that looks for HIV-1 and HIV-2 antibodies. And that's really our confirmatory test. So if that is positive, that confirms infection. If it's negative or indeterminate or there's discordant results, then we go down, if you follow this algorithm, to the right side of your screen. You would do an HIV RNA, and then if that's positive, diagnose an acute HIV infection. So kind of going through, okay, there we go. So our initial HIV antigen antibody tests are really good tests. So they have greater than 99% specificity. However, it's important to know that there are false positives that are possible. And I think that's really important to know, especially doing these tests in the ED or being able to kind of help guide your patient through the initial positive is that there could be false positives with these tests. So they most commonly occur with pregnancy, recent vaccination, autoimmune diseases such as like rheumatoid arthritis, EBV or mono infections, some malignancies, TB, and rarer infections like schistosomiasis that we see in parts of Africa. So when the samples that are reactive for the initial screening tests are positive and the reflex differentiation assay are both positive, that's considered a positive test. And the specificity of those two tests combined increases to nearly 100%. So really, really excellent specificity. So it's important to understand when these tests are positive, just kind of briefly going through, and then I'll talk about the implications of knowing when these tests are routinely become positive. So initially, the blue line is your HIV RNA. Those typically become positive at about 7 to 10 days, as early as 7. And that's your first test that will become positive is your RNA. The antigen becomes positive later, anywhere from like 10 to 14 days at the earliest. The average is about 16 days. And then that's followed by your antibody. So when patients seroconvert, it's a little bit later. So on average, about 23 days after the initial infection. And then you have acute HIV, where you have this rapid increase in HIV RNA, anywhere between days 20 to 25, 23-ish. So why is that important to know for you guys? So it's important to know because there are these window periods where the time between exposure and the time the different tests can be positive is this window period where you might have falsely negative testing. So like we said, the fourth generation or your initial screening test, because it uses this P24 antigen, it can be as positive as early as 10 to 14 days. The average is 16 days. So it could be negative if the exposure was earlier and falsely negative if the exposure was earlier. And then, like we mentioned, the antibodies develop even later, starting around day 23. So why is this important? Like I mentioned, if they had a recent potential exposure, they might need repeat testing. Even if they had an exposure as early as 10 to 14 or as recent as 10 to 14 days before, that fourth generation or that initial screening test could be falsely negative. So it's really important to get a good history from your patients. And then the other potential problem with these window periods is that you could have discordant results. So, for instance, if somebody has acute HIV infection, their screening test might be positive because of that P24 antigen. So the initial test might be positive, but then the reflex to the antibody, the differentiation assay could be negative. So if you have those discordant results, and it's possible that someone's between those days of like 10 to 23, or even a little bit later where they're not seroconverted yet. And in those cases, if you are suspecting an acute HIV infection, so somebody has signs of acute retroviral syndrome, meaning fever, lymphadenopathy, rash, sore throat, that kind of thing, or a recent exposure, you might want to consider sending an HIV RNA. And that's helpful even if done in the ED because it does require a separate sample to be drawn. And if that is positive, that can confirm a diagnosis. Whereas if it's not drawn, you might have to wait. The patient might have to wait some time before they get their final results. And then this is just an illustration outlining those the window periods essentially. So the important ones I wanted to highlight is this antigen antibody, the fourth generation. The lab tests are usually on average start to be positive around day 16. And then the antibody is usually around day 23. So keep in mind those window periods. Are there any, let me just talk about opt-out testing and then I'll ask for questions. So opt-out testing, the law has changed for HIV testing and nowadays it does not require that the patient is provided a special or a separate consent. And it is known that general informed consent is sufficient for just general medical treatment. However, before HIV testing, the patient must be informed that an HIV test will be conducted, and then the patient just has to have an opportunity to ask questions, and they can opt out. But it's a little different than previously, where they had to provide consent specifically for HIV testing. So any questions about the screening test, the window, the opt-out testing? And feel free to enter something into the chat, or you can unmute yourself and talk. I'm happy to have a discussion.
I don't see any comments in the chat at the moment. Brianna, I do have a question.
Yeah.
And maybe some others will come up. I'm curious, does it matter in the sense of outcomes and timeliness of treatment regarding like identifying HIV infection more quickly? Because you're mentioning, the possibility of doing an RNA, and certainly I can see the benefits of like, really knowing the diagnosis just in general more quickly. Does it impact or how you treat or outcomes tied to treatment?
Yeah, I'd say so. I think in those cases of discordant results, like I mentioned, it's possible that we do see false positive initial screening tests, so the fourth generation. We do see those false positives, like I mentioned, most commonly with things like pregnancy or autoimmune diseases. So if you have a discordant result, like that first test is positive and that second test is negative, you can't start somebody on treatment until you have a confirmation, and that would be done with that viral load. And so I think that would definitely, getting that initial RNA test earlier on, if you're suspecting that might be the case, would at least save several days of treatment delay. And then that's also not including the times when the patients that are difficult to contact, have difficulty following up, have difficulty even getting to the lab. So that could even delay things much further.
Thanks.
Yeah. Okay.
Chris, you've got a comment there.
I do, yeah, actually, exactly to that end. When someone screens in the emergency department, we try to be as efficient as possible, and most places do their screening and then their confirmation if it's positive on one blood sample.
Yep.
And I know there are several sites that are looking to actually use that sample or samples that are still present in the lab after the patient leaves, because the turnaround time on the confirmatory on the diff is, a day or so.
Yep.
Why is it that it's important that the RNA be a separate sample?
Yeah, based on the lab characteristics, I'm not entirely sure. I think it might have something to do with the it might be the tubes or something along those lines, I can look into like ask our lab personnel and get back to you. But I'm not. It's just it's like it just requires a different collection. So I'm not sure if it might be like a different tube or something along those lines, or a different way the specimen's handled.
Not that there needs to be a time interval between the two.
No,
Right.
definitely not. Nope, it's just a specimen, a laboratory thing.
Yeah, there is actually a comment about it needing to have a dedicated tube.
The tube is a tube. Okay. Yeah. Okay. So I'll move on. So I'm just going to talk a little bit about communicating this initial positive test. It's important to be clear, if that's all you have in the ED, you get this initial positive test and you need to communicate this. It's important to communicate it in a way that's not saying that they are diagnosed with HIV at that time. So you have to be clear that it's only a screening test, that you have to wait for the second confirmatory test to know if this is a true HIV infection. Was mentioned, this automatically does reflex at most labs and from the initial 4th generation to the differentiation assay. So that's that same sample. And most labs take about a day, maybe up to a day, a couple days more for the results of this test to come back. So it's important to, reassure the patient, and say, we just have to wait. This is not confirming the diagnosis. We have to wait on this confirmatory test and just provide reassurance. That can be a tough waiting period for patients, definitely. So we talked about the confirmatory testing that confirms the diagnosis, and then when really delivering the diagnosis of a confirmed HIV infection, I'm not sure how often this is done in the ED, but I imagine it does happen. You want to really, make sure that the patient is in a private area. If they're in the ED, not like out in the hall, or if you're delivering the results over the phone, make sure that they're alone. It's a good time for them to talk. And be direct and neutral about the news. This can be done by any healthcare personnel. Then, like we mentioned, it's followed up with a viral load. But if you have those initial 2 tests that are both positive, that does confirm the diagnosis. I do want to mention here, and we'll talk more about it later, that if people test negative for HIV, but they are high risk, this is a good opportunity to at least mention and discuss HIV PrEP, and if they're interested, get them referred. And we'll talk a little bit more about that later. So a lot of questions come up, obviously. This is a huge diagnosis. So the most, I actually spoke with our nurse, Sharon, who does takes our HIV ED positives and communicates them to the patients. And so we went through a lot of the common questions that patients ask. So they'll ask, is it treatable? And so, the answer is yes, it's very treatable today. HIV treatment is very successful today. Really, and this is kind of one of the take-home points of this entire talk, is that nowadays HIV is really managed as a chronic illness. I liken it much to like diabetes or hypertension, where yes, patients will need to be on their medication and stay on their medication and have regular follow-up, but they can live long, healthy lives as long as they stay in care and stay on their medications. So really framing it in that way, that it is like a chronic condition these days, I think helps to ease patients' minds when they get this really, big news, this huge diagnosis that was once thought to be a death sentence. So really kind of hammering that home that our treatments are very successful today is important. There is no cure, but like I always kind of follow that up with, we're always working on new treatments, better treatments and cures, but it really is just like a chronic illness nowadays. So like I mentioned, you just really want to stress the importance of treatment compliance and getting into care. And they can have a really good life expectancy if they are compliant with their care. Patients will also ask about risk of transmission to their partners. So upon initial diagnosis, it's really important to counsel patients to abstain from unprotected sex. And a lot of times we will briefly go into U equals U. I'll go into this a little bit more further later in the presentation, but U equals U is the undetectable equals untransmissible. And so that's like a really good way to motivate patients to get on treatment, is saying, once you're undetectable, you will not be able to transmit the virus, and that can provide some reassurance. So they will also ask about, or they often ask about, disclosing their HIV status to their current partners. And really, it's, if they feel safe disclosing, it should be encouraged. But, and in our HIV clinic, we help people with this all the time. We can actually bring partners in to get tested. But all positive tests are reported to MDHHS, as you guys are well aware. And we always recommend that patients should be told that they should expect a call from the health department, because sometimes that can be surprising. And they do help with partner notification, and will protect the identity of the person living with HIV. So any comments on that? I know that you guys are heavily involved in that process.
No specific comments that I'm seeing in the chat, but definitely agree. These are important talking points. I think that we all should be comfortable with talking about in the ED setting.
Yeah. Okay. So then, going on to, from that initial diagnosis to getting them linked into care, the ideal is that they get into care and started on antiretroviral therapy, or ART, within 7 days. And that's one of the key pillars of the ending HIV epidemic. And so factors that are associated with delayed linkage, and we see this often, unfortunately, are things like substance use, lack of insurance, if they, at the time of diagnosis, don't have a primary care provider, or if they live in a high poverty area. I think another huge barrier that we face is that a lot of patients don't have working phones or reliable contact information, and so that can be really challenging too. So at Forward, I just wanted to briefly mention our process. So the positive EG tests go to one specific HIV nurse in our system, and so she looks into if it's a new diagnosis, if they were formerly diagnosed but just out of care, if they came from out of state, et cetera. And so she also contacts MDHHS, and then if she determines it's a new diagnosis, she will reach out to the patient. And she'll make a couple of attempts, and then if she can get in contact with them, she does let them know about their diagnosis and kind of talks them through, answers questions, and then she sets them up with an appointment. Usually we're able to set people up with an appointment within a couple days. That's our goal. But are ideally within 7 days is when we want to see them in our clinic. And then if she cannot reach them, she turns the case over to the health department. So that kind of brings me to now our patient comes to clinic. And this is really where I can, provide a lot of insight from my perspective of seeing these patients in our HIV clinic. So I really like to go through kind of the, like I mentioned before, when you give the initial diagnosis, but also when they come to clinic, really navigating them through what it looks like to live with HIV these days in 2025. So I always tell them, with the advent of new medications, it's HIV is now a chronic condition. Sometimes I even mention, in some cases, it's even easier to manage than diabetes, like we don't have insulin, things like that. And that always, I think, kind of eases people's minds a bit, makes them realize that this is truly a chronic condition. And I also will walk through, how HIV works, right? So how it infects and destroys your immune cells. So we look at, if I already have the labs, we look at the CD4 count, and I explain those are your T cells or your immune cells, and HIV acts to destroy those, and that is what makes you susceptible to other types of infections like bad pneumonias or different types of infections like that. So I kind of walk through that. I discuss, the importance of medication adherence. Of course, I answer questions about the medications we're going to start them on, but I talk a lot about the course of how the once we start ART, how that impacts the viral load and when to expect them to become undetectable, when to expect their CD4 to get above 200 if they start below 200, and all of that. And so I really, a lot of time, I'll go through this with a little bit later, but I spend a lot of time on that because I think it helps to motivate people to stay on their medication and to stay compliant. And it also gives them some hope in the process. We talk about U equals U, so undetectable equals untransmittable. Talk about life expectancy, and then overall, like I'm the really the take home point of this entire talk is just to provide reassurance to these patients. So it can be a life altering, really scary diagnosis. Of course, you want to provide support and acknowledge that this is a huge diagnosis, but I really try to be able to provide reassurance to my patients when I'm seeing them in the clinic, especially for the first time. So common questions at the initial visit. So sometimes you get some of the same questions like I had mentioned previously, but then patients often ask like, when did I get it? How long have I had it? So we'll go through together, we'll go through kind of their history, their medical history, and I often ask about a time when, like if they had any unidentified flu-like illness, and sometimes people can point it out. I've had patients say, yeah, last summer I had this weird flu-like illness. I got like swollen lymph nodes and fevers. I was tested for flu and mono. They were negative, and I was just sent home. And so sometimes we can say like that could have been it. So I work with them through those scenarios, through their, we talk about prior partners, anyone with either unknown HIV status or known HIV status. And then we also look at their current CD4, if I have it, and that can give us some insight into how long they've had HIV. And I'll go through what those numbers look like and what that can tell us. But I really, we spend a lot of time on that because patients often have those questions. They'll ask, do I have to tell future partners? And we do discuss that it is it is required by law that you disclose your HIV status to future partners now that you know that you have HIV. They ask, I've been asked at like the very first visit, can I have children? And so usually this is a good opportunity to talk really close to you, especially if it's a female. So we talk about if they're undetectable, there's an extremely, extremely low chance that they would be able to transmit it to their baby. So we, usually I provide reassurance there, especially for men, like yes, and again, it kind of all circles back to the importance of becoming undetectable and staying compliant on their medication. They ask about side effects of the medications. We'll talk a little bit about that later in this presentation. And then I often get the question, will I have to take this for the rest of my life? And right now, the answer is yes. We do not have a cure. If they become undetectable, I try to lay this out in the very first visit, is that if you become undetectable, it's so important that you stay on your medication, because if you stop taking your medication, the virus will come back. And that sometimes is not common knowledge, and so going over that is really important. And then people will ask about their life expectancy. I think the traditional frame of thought is that this is a death sentence again, or they're gonna die young because of this diagnosis. And I really, again, reassure that we have very similar life expectancies nowadays, as long as patients stay compliant on their medication and remain in care. Okay, so kind of going back to that question about when I could have gotten HIV. So sometimes if we, depending on the CD4, we can kind of ascertain when somebody was infected. We're definitely not able to pinpoint it, but we can kind of give a ballpark. So a lot of times I will actually draw this chart and I'll show them, so at about 200, your CD4 will go below 200. Usually it's pretty late though. It's about an average of 7 to 10 years before your CD4 will drop below 200. And so if somebody has a CD4 of less than 200, if they're at 100, I say you probably have had HIV for at least 7 years, and that's a ballpark, and it's an average, and I always kind of give that caveat, but generally speaking, they've had an infection for quite a long time before they have advanced HIV or AIDS. So that's really important for people to know. It's a very common question. Okay, so at the initial visit, we do a really, really thorough history. So we ask about their HIV history, their prior partners, their sexual history is very important. Other medical conditions, substance abuse history. We do a thorough physical exam, really looking for, especially either if I don't know the CD4 or if they have a low CD4, I do a really thorough physical exam looking for signs of opportunistic infections, so thrush, Kaposi's, lesions, that kind of thing. And then really a big piece of that initial visit is supporting them. So coping strategies, making sure they have a good support system, kind of talking through their financial status, their housing, their relationship status, just really getting a sense for, where they're at with things and how we can support them. And we're lucky enough to have a lot of support from our social workers to do that as well. So initial labs, we always get a set. Some of these are already done by the time they get to us, some of them not. But generally speaking, we like to get that initial viral load and CD4 if we don't already have it. And then often we'll get a genotype, so looking for resistance. We get a complete metabolic panel, CBC, quantiferin, looking for history of TB, lipids, UA, hepatitis screening, STI testing, and then we'll get a toxoplasma IgG. And then, depending on their CD4 and depending on their symptoms, we might get co-infection or looking for opportunistic infections as indicated. And then we go on to discuss the initiation of ART and the importance of medication adherence. So I'll talk about more about the options for antiretroviral therapy these days. But this is kind of what I was mentioning at first at that initial visit when I talk about what happens when we start you on treatment. So I actually draw out these charts for my patients and I say, your viral load starts up here. This is at time 0. And then really once we start ART, it'll drop quickly. So this is even a little bit more delayed than what we often see with some of the newer medications like Biktarvy, for instance. We often see within the first month to 2 months that people rapidly drop and become undetectable. So I draw that out because I think that it's helpful for patients to see that, okay, if I start this medicine and I'm very compliant with it, that my viral load will drop very quickly, likely within a month or 2 to undetectable, and that's motivating. So then this is what I was mentioning with the CD4. So the CD4 takes longer to recover, especially if it starts off at a lower point. So starting at time 0, often it does take, if you start off at less than 10, it says less than 100, so that red line, it can take a couple, at least a year to get above 200. And really moves slower, but it does improve with treatment. As the viral load becomes suppressed, the CD4 will go up. It just goes slower as if you start out at a lower base point. And so I draw that out as well. Sometimes on that same graph as the viral load, I'll draw out the CD4. So just so they have an expectation of how quickly their immune system will recover. And I use that as, again, motivation to take their therapy because I talk a lot about if your CD4 is less than 200, it means you're at risk for these infections like bad pneumonias, like meningitis, like certain types of cancers. So it's motivating to stay compliant with treatment. Okay. Any questions about those kinds of things, like what I go over in clinic in terms of the viral load, CD4, questions in clinic, that kind of thing?
Brianna, I don't see any questions specifically about that, but there is a comment in the chat.
Yeah.
And it's a little bit hard to summarize. It's more about I think testing or exposure to healthcare workers, in a healthcare setting? Um,
Um,
Timeline is screening, and whether or not there
yes.
should be repeat testing.
Okay. Yeah. So that I'll talk a little bit more about. Maybe I'll save that until we talk about post-exposure prophylaxis. I think that's
Mhm.
what you're getting at, Sarah.
I think you're right.
So I do have a little section on that with some updates, and we'll talk about that. And you're asking about what testing to send. Okay, yeah, we'll talk about that when I go there. Thank you for the question. Okay, let me just get to my. Okay, so I'll keep moving unless anyone else has any questions. Okay, so U equals U, I think most people are familiar with, but a lot of patients are not. So this is, again, a really important thing to discuss at that first visit or even at that first diagnosis is just the concept of undetectable equals untransmittable. And this has been studied extensively and is well understood that if people have an undetectable viral load for at least 6 months and they're continuing on their treatment, there's no risk of passing HIV on during sex or vertical transmission, like during giving birth. And so that's why it's become a slogan or like a campaign because it is empowering, right? So if you know you're undetectable, it feels like there's less stigma or like um, less chance of passing it to somebody else, less risk. So people, the concept is really it's really well taken by people. So I go over that as well. So now we'll talk about treatment, and I think the history of HIV is fascinating, and I could spend a lot more time on it, but I won't. But we'll kind of talk about where it started out, and where we are now. So back in the 1980s, so the initial morbidity and mortality weekly report of HIV/AIDS was published in 1981. There were cases of pneumocystis pneumonia and Kaposi sarcoma. At the time, so in 1982, the median survival was just 8 to 15 months, and these were all like mostly young men. So that was devastating, and there's a lot of history there that is really interesting to look into. But the initial AZT trials were done in 1987. So they were this study was published in the New England Journal of Medicine in July of 1987. And it was actually stopped early because the treatment was so efficacious over placebo. However, it was, there were a lot of side effects with AZT. So significant bone marrow suppression requiring transfusions. And then they started to see AZT resistant virus emerge, unfortunately. So the hope that came with the advent of AZT kind of quickly faded. But then the next kind of wave of success in ART or antiretroviral treatment came with protease inhibitors, and they were introduced in 1995. So prior to that, the deaths were up in the 20 to 40 deaths per 100 person years. And then when protease inhibitors were introduced in 95, these deaths plummeted. So it was pretty amazing, pretty miraculous. And so from there, we've really come a long way. This is just kind of highlighting, that initial diagnosis or the initial case reports in 1981, followed by AZT in 1987 or zidovudine, and then in like the mid 90s is when they started to come out with highly active antiretroviral therapy, and that became the new standard of care for HIV. So this, I think, is a really good take-home point for this presentation as well. Basically, so in 1987, really the goal was just to delay progression of the disease and not to for people to live long, healthy lives otherwise with this chronic condition. It started out with zidovudine monotherapy or AZT. And kind of in the mid 90s, even to early 2000s, it was a triple drug ART, but there were multiple pills. As you can see in this depiction, there's like a handful of pills a day, and they had to take it multiple different times a day. There were a lot of side effects. So effective treatments, but difficult to take. And then now in the mid 2020s, we have highly effective and tolerable 2 and 3 drug ART regimens. Most of them are single tablet. And then we'll talk about injectables as well. But really the goal now is to maintain virologic suppression and have really, good quality long lives. So what it's like living with HIV these days. So like I said, most of our patients are on single tablet regimens. They have really minimal side effects. They're well tolerated. I won't belabor this, but these are just the first, the standard guidelines for initiation. Oftentimes, we will do rapid starts for our patients. If they don't have, if it's a new diagnosis and they don't have a history of using cabotegravir for PrEP, which aren't a ton of people, most patients are able to be started on Biktarvy, which is bictegravir, TAF, and azacitidine. And that's kind of our standard, our go-to. Again, most of the time we'll do rapid starts before we even wait for a genotype. Biktarvy is, like I said, very well tolerated. Kind of the most common side effects that I consult patients on are what's called almost like a startup syndrome. So patients can get like headaches, some GI upset, a little bit of nausea, and that usually goes away on its own as they continue to take the medication. Within, always say like a couple of weeks to a month, that goes away. And it's not all patients, it's maybe less than 10% of patients. I really haven't had anyone not be able to tolerate it. I'm sure they're out there, but overall, very well tolerated medication. We also do have this 2-drug regimen, which is dolutegravir lamivudine or Dovato, but those do have some exceptions. So we have to have a genotype, the viral load has to be less than 500,000, and they can't have a hepatitis B co-infection. So there are some stipulations there. We don't often initially start somebody on that regimen. There are a lot of other single tablet regimens that are well tolerated and highly effective. Kind of a second line is if you guys have heard of Simtuza, and that's still using a protease inhibitor, darunavir. That's in that second line here. So that brings us to kind of the newer kid on the block is the long-acting injectables. So CAB rilpivirine was introduced in January of 2021. Initially, it was approved as a switch option for monthly injections. And then in 2022, it was approved for every other month. So nowadays, with exceptions, we have some patients that we have on monthly injections, but most patients can be switched to every other month injections. And there's a 7-day window period for missed injections. The side effects are even less, they're quite minimal. The most common is injection site reactions, but overall they're pretty well tolerated. So generally speaking, it's just very nice because we have this array of options now. We have really well tolerated single tablet regimens that are once a day. We have injections that are every other month, and kind of everywhere in between. So we have a lot more to work with, which is pretty amazing from what we came from back in the early 1980s. And then, like I said, patients will often ask about life expectancy. So I always try to reassure patients that really you have a similar life expectancy to somebody without HIV as long as you stay on your medication. So this kind of picture depicts that if somebody acquires HIV at age 20 and takes their ART, their life expectancy is 71 years as compared with somebody without HIV whose life expectancy is 79 years. So really pretty similar. The most common things that we're seeing nowadays, and this is really where the field of HIV is going, is we're learning more and more about managing other comorbidities with HIV infected individuals. So we're seeing a higher rate of things like weight gain, obesity, cardiovascular disease, as well as certain types of cancers. And a lot of it's multifactorial, but some of the underlying thought is that with HIV, even if it's well controlled, we have underlying levels of inflammation that predispose individuals to things like cardiovascular disease and malignancies. So really that's kind of where the field is going, is managing these as, again, chronic conditions. Okay, so that's the extent of my talk for focusing on linkage to care and then getting them into care and kind of what treatment looks like today. So any questions on that before I briefly jump into post-exposure prophylaxis and PrEP?
I didn't see any questions so far in the chat.
Okay.
I don't know if there are others though that want to unmute and ask questions now.
So what are the leading causes of death? Are they related to neoplasms from the HIV infection, or are they the same cause of death as the general population?
Yeah, so there's like two different types. I mean, they divide it into HIV associated malignancies and non-HIV associated malignancies. So they are seeing increased rates in both. And so not necessarily like they're not opportunistic infections, but they'll still see higher rates of lymphomas and that kind of thing, which are more associated with HIV. But then they do still see higher rates of breast cancer, colon cancer. We see a lot of anal cancers associated as well. But again, that like underlying increased inflammation is thought to account for the non-HIV associated malignancies. And I think there's a lot of research that's being done looking at specific types of cancers that are more associated. Off the top of my head, I couldn't like list specifically, but there's a lot. That's a huge area of research that's ongoing. Okay, any other questions right now? Okay, I'm just going to quickly talk about. I couldn't do a talk without discussing a little bit about post-exposure prophylaxis and PrEP. PrEP is one of my big areas of interest. Just wanted to go through, and I think this will answer that previous question in the chat a little bit. Is the algorithm for possible HIV exposure? So this is non-occupational, but I can mention occupational as well. It's a similar kind of process. So the big thing to remember is 72 hours. So if they're within 72 hours of exposure, there would be an indication for post-exposure prophylaxis. And really it depends on their risk of transmission, and that depends on the exposure of like which body site, and then with which type of fluid, and then who it came from. So in the category of the like substantial risk for HIV acquisition, it would be exposure of the vagina, rectum, any mucous membrane like eye, mouth, non-intact skin, or like percutaneous contact, so like a needle stick. And then but the type of fluid matters. So it has to be something like blood, semen, vaginal secretions, rectal secretions, breast milk, or a fluid that's contaminated by blood visibly. And then it's, of course, extremely high risk if the source is known to have HIV. So that's when you consider it like a substantial risk. If the source person is unknown HIV status, it's really a case-by-case determination. And it's really, when I get these calls, I talk through, what was the exposure, what were the secretions, and then a lot of times, if it's kind of in a gray area, it's really discussing the risks and the benefits of PEP, post-exposure prophylaxis, with the patient. And that's what I always recommend if it's kind of in that gray area of like, say, for instance, it was a needle, it was just a lower risk exposure, like someone that, the source was unknown status, and the contamination was with something that was not blood, or it was like with saliva or something. It's really a case by case determination. information. I think you had asked about the labs. We have them on our Henry Ford guidelines. I'm sure online there's somewhere that you can pull up there's a chart, but basically you want to get like your rapid or point of care or lab-based HIV antigen antibody tests. You do want a viral load. And then you also, if it's like you had asked like a needle stick or something, you want to get hepatitis B serologies, hepatitis C testing. And so that's for occupational exposures. And then if it's a non-occupational or like a sexual exposure, you want to get STI testing, pregnancy tests, all that. And then there's routine follow. So that's at baseline. And then there's routine follow-up. It depends on the exposure. So I won't go into it too much, but usually it's like initial repeat testing is like 4 to 6 weeks, and you at least do HIV and hepatitis B. And then you retest again at 12 weeks for at least HIV. And I'm kind of glossing over that because it's a little complicated and nuanced, but there are those guidelines that are available at different, and I think it's available on the CDC website as well. The big update that I wanted to show you guys is CDC in 2025 made updates to their post-exposure prophylaxis regimen. So previously it was a 2-pill regimen with dolutegravir and then usually Truvada, but now it's actually the preferred regimen is Biktarvy. So that's actually, I think it's an important update because adherence is much more likely. There's a lot less risk for medication errors, all of that with a single tablet regimen. The course of therapy is 28 days, and then it's still recommended that they follow up with either us, an ID, or their primary care provider. So then just a bit on pre-exposure prophylaxis, so protecting people from getting HIV. So only about a third of patients that could benefit from pre-exposure prophylaxis in 2022 received a prescription. So there's still a huge need. And a recent study that was published this year actually showed that the highest PrEP coverage states experienced a 38% drop in new diagnoses in the 10 years from 2012 to 2022. But the states with the lowest PrEP coverage saw a 27% increase in new diagnoses. And I think that's just a pretty stunning statistic. I won't belabor this, but this is just showing in Michigan the PrEP to need ratio, which is basically the number of PrEP users to new HIV diagnoses. So the lower PrEP to need ratio number, the higher unmet need for PrEP. And so in Detroit and Wayne County, we have a PrEP to need ratio of about 8, which is not very good. So a lot of work to do, and there's a lot of racial and gender discrepancies. So females have an unmet need for PrEP, and then also Black and Hispanic patients also have a higher unmet need for PrEP. So just kind of wanted to touch on, I know that I'm running out of time, but who meets criteria for PrEP? And it's a lot more than we think. So basically anyone that's sexually active in the past 6 months, if they've had one or more partners with unknown HIV status, or if they've had a bacterial STI in the past 6 months, that's actually an indication for PrEP. And so PrEP should be offered and prescribed if they meet those criteria. Similarly, with injection drug use, if they've used shared injection equipment in the past 6 months, that's an indication for PrEP. And if you notice kind of in all these, like if you go to the no at the very end, even if they meet no for everything, they still recommend that you discuss PrEP, you tell your patient about it, and you prescribe it if requested. So definitely just a lot more patients that we're missing in that bucket. There's oral options. So as you guys know, Truvada or Descovy for PrEP, they're taken once a day and pretty well tolerated and safe. I'm not going to go into this too much. And then there's injectable options for PrEP. So cabotegravir is given every 2 months. It's an injection. And then the really fun new kid on the block that's really exciting is lenacapavir, which is a first-in-class capsid inhibitor, and it's only given twice yearly, so every 6 months. And the data is really excellent for it, and it was FDA approved in June of 2025. We're working on getting on our formulary at Henry Ford. I'm not sure if anyone else has had experience with it, but it's it's going to be coming. I'm hopeful. So it's exciting. So getting prep to your patient, especially from the ED, you can just discuss it with them and refer them to ID. We do offer tele prep, so all virtual at Henry Ford. A lot of PCPs will prescribe it. And then I just wanted to highlight, we do have a 24/7 HIV specialist hotline through our ID department. So one of us is always on call at this hotline number. And I have the number listed. So you can ask any questions about HIV management, PrEP, post-exposure prophylaxis, anything related. Also STI questions at this number, and we're always available. So I'm not going to kind of belabor those because I know I'm out of time, but I think the big takeaway that I think I wanted everyone to get from this is that, treatment has come a long way and our modern regimens are extremely effective, well tolerated, easy to take, and really providing your patients reassurance that this is more like a chronic condition and that they can live long, healthy lives as long as they are compliant with their medication is the most important thing. And with that, thank you all so much. And I'm open to any questions. I know that it's the end of the hour, but I really appreciate your attention.
Thank you, Brianna. That was awesome. Do we have time for one question if anybody has one they want to offer in the chat or come off mute? Yeah, thank you. All right, maybe we'll leave it at that just because we're close to the top of the hour. Again, thanks so much. I certainly learned a ton. I think you've given me a lot of ammunition for the next time that I'm in these situations in the ED to help patients navigate this tough situation. Certainly making the case for screening given the reality about asymptomatic infection. So thanks for adding to our knowledge. Just a couple housekeeping points again. Sam, if you can provide that QR code again, if you can complete this short survey, just to help us understand the impact of our program. And then I'll just point out that we have our actually last learning series seminar coming up in the new year in February. So please be sure to mark your calendars for that. And we plan to kind of wrap up some of the experiences people have been accumulating as they're implementing their programs in EDs around the state. And then if you want CME credit, please be sure to apply for that. It's through the University of Michigan, and there's this 7-day deadline. Just remind yourself that you have to get it applied for within a week. Sam will follow up with an email just with more details about that as well. All right, let's. I guess we'll wrap it up there. Thanks so much for your attention, and have a good holiday season. Happy New Year.